Thank you. Certainly.
So the talk today is about neonatal hypertension, which I'm sure is the reason you all became interested in neonatology. So I'm hoping that this won't be just be a list of things, and I have a couple cases in that we can make it a little interactive. The goal today is really to let's see if my screen will move. There we go.
1, 2, 1, 2. It's weird. It's like if the is working.
Oh,
Just want to make sure before you start that.
hello.
Yeah, I don't see it move. Can I just
Yeah,
leave it?
please.
1, 2, 1, 2. Microphone, noise removal, original sound from musician. Wow, that's very impressive. Maybe what I'll do is that I will log with my phone and then I'll let you
Sure.
use my phone. Zoom workspace. Sorry about this. Teaching, join, authorize.
Recording in progress.
Can you say something? Oh, so it's working. Sorry about that. Okay.
All good. All right. So, yeah. And so today I'm not, it's going to be more of, I guess, a general look at neonatal hypertension, but with a specific focus, hopefully, on some of the things that you are more likely to see in the NICU. And so we will talk about some of the factors that influence neonatal hypertension as well as defining it. And then there are, especially nephrologists, especially, we are kind of particular about how we measure blood pressure. And so we'll discuss some of those elements as well. And then hopefully we can spend more time sort of discussing cases and highlighting some of the causes and then the diagnostic workup of both sort of mild to moderate hypertension, but also severe hypertension in the NICU. So you are certainly more likely to see hypotension in your practice than hypertension. However, we do know that premature babies are at higher risk for developing hypertension in the future. And there are a number of conditions that you guys also see regularly that place babies at risk for developing hypertension. We'll discuss some of those as well. So in terms of some of the things that influence blood pressure, we can sort of, and this is not just necessarily hypertension, but what a baby's blood pressure is when they're born. You can kind of divide it into three separate factors. So the main ones from like a maternal element, so antenatally, we do know that there's a higher association with hypertension in babies who are born to hypertensive mothers, and specifically any sort of placental pathology or vascular pathology. Um, like, preeclampsia, for example, where we know that the risk of hypertension is higher. We do, of course, know any maternal medications or especially substances like drugs, cocaine, that type of thing is associated. There have been some studies looking at maternal age and maternal diabetes as being affecting blood pressure or being associated with hypertension, and those we don't have quite as much evidence to support. From like a perinatal perspective, so the only thing that has really been shown to affect blood pressure um, within or around the time of delivery are perinatal steroids. And that's usually even, when it's within 7 days of birth. And typically, if it's earlier than that, then we don't really see as much of an impact on the blood pressure. Um, and then even magnesium, labetalol, delayed cord clamping, and even C-section versus vaginal deliveries as well don't have as much evidence supporting any association with changes in blood pressure either. But what I would say is that the factors that most influence blood pressure are the infant-related factors and specifically related to the gestational age at birth, the and the birth weight, I should say, which I don't think is really shocking to any of you, right? Like you've seen 24-week babies and 32-week babies, and the 24-week babies have lower blood pressure. Same, I think, in terms of like increased blood volume. I know we had said that delayed cord clamping didn't really seem to affect blood pressure. I think the blood volume is probably just more reflective of the baby's size. We know that smaller babies will have smaller blood volume, bigger babies will have a bigger blood volume. That's kind of how I interpret that finding. But this is just essentially a diagram that kind of covers everything that we just talked about. So anything in green has been shown to be associated with affecting blood pressure. Blue is kind of equivocal or not enough evidence, and red is that there's not really any association. And so again, like we said, the ones that are most likely to affect blood pressure, not really groundbreaking, but are all of our infant factors. And then after babies are born, the degree to which their blood pressure changes over time is also affected by their size and their gestational age at birth. So again, like we said, when we compare like prems versus extreme prems. Obviously, the extreme prems are going to have lower blood pressures, but we can also see that over the first couple weeks of life, the rise in blood pressure is significantly quicker than babies who are born premature. Similarly, term babies versus term small for gestational age babies as well. The small for gestational age babies will have lower blood pressure with a more rapid rise in blood pressure over time. But then it all kind of evens out after a few weeks. This is kind of just saying the same thing again. And then these are the tables that we typically use. So they're the systolic, these are just the systolic mean and diastolic blood pressures. For like at 2 weeks of age, based on their gestational age at that time. And just to give you an example, like if we look from 26 weeks to 30 weeks over that 4-week period, this is the 50th percentile, goes up by about 10 millimeters of mercury. Whereas let's say you look from 32 weeks to 36 weeks, it only goes up by 4 over that period of time. So just again, kind of highlighting that you have a much more rapid rise in expected blood pressure earlier on. And then this is also after a period of, so basically, they kind of use this more for like term babies, but for like a 7-month-old or 7 to 12-month-old, really after 2 months, these are the different percentiles for systolic and diastolic blood pressures that we use. And you'll notice they're quite generous, right? Like the 95th percentile being 110 for a 2-month-old, for example, and so this is kind of reflected in how this data came about. It's not exactly like we measured a bunch of babies. It's sort of more extrapolated from other data that we have. Because also, to give you an idea, after 12 months, suddenly the values change, and what is considered hypertension in a 12-month-old is actually lower than what we would consider in an 11-month-old. So the data and how we don't actually have it all figured out, and they're kind of flawed in how we determine what is considered hypertension. More so, I guess, later in infancy. But just, I guess, something to keep in mind that it's not perfect. And so, yeah. So in terms of how we measure blood pressure in neonates and what a lot of these norms are based off of is the gold standard by far is the intraarterial measurements, which you guys are familiar with. Obviously, whether it's the radial artery or the umbilical artery is really more just a question of what is easier to place and what what you can kind of consider more reliable. Um, Typically used more in the early prems and the like more critically ill infants, but of course has its risks. And so for other patients, the way that you guys that mostly do it would be non-invasive blood pressure measurements with like oscillometric devices or automated blood pressure measurements. And so this is where we, the nephrologists, get very particular, and we're always asking, where did you measure it, and where they come, and all this stuff. I will say that probably most of this we would ask about. I think the timing part probably we're not going to focus. Anyway, it's not exactly practical, but we want to make sure that it's measured usually on the right arm when possible in the event that are you dealing with like a coarct or something like that? And what we can talk about that and how to investigate that a little bit as well. Calf blood pressures are typically more practical. The cuffs fit a little bit better, but they tend to have a lot more variability and often tend to overestimate the blood pressure. And then the cuff size also matters. So the way that it's measured basically is that the width of the cuff is 50% of the baby's like maximal arm circumference. Um, and I don't think we're gonna ask you if you measured the baby's arm or anything like that, but ideally we try to make sure that it's best or it fits well, which again can be challenging in smaller babies. And then the timing, this is based on the guidelines. I think you're going to have a hard time finding a moment to do this in the NICU. And I think nurses, yeah, exactly. And like, I don't think nurses will be very, very happy. But
Gonna fly.
And so I don't think anyone is going to expect you to have done this. But, that's what they typically say is that it's like, oh, an hour and a half after the feed, because now they're not eating, they're comfy, they're not hungry, they're calm. And then you place it on them and allow them to get used to having it on before measuring the blood pressure. Again, not exactly practical. And then also, again, not really practical. This is more something that, we will do in like our clinics when we're seeing infants. But we will often do manual blood pressures via a Doppler assessment. So we'll place a Doppler on the radial artery with the cuff on, and essentially inflate until we can't hear the pulse anymore. And then once you hear the pulse, that's your systolic blood pressure. It just gives you the systolic. You can't get the diastolic with this. And again, it's pretty impractical to do this on a regular basis as well. But we might do it if we really wanted to be sure.
You could almost do it with an ultrasound.
Yeah.
Like you occlude and then you see no pulse.
Yeah,
and
yeah,
The minute you start seeing the pulse,
Exactly.
it's your systolic peak.
Yeah.
Interesting.
So that's essentially what we do in the clinic, for example, when you can't really do a manual blood pressure on like a 4-month-old or something. So when we compare the two, invasive blood pressure measurements are definitely more accurate, especially if you have a well-placed central catheter. The non-invasive methods generally can correlate reasonably well. The way that they work is that actually the like oscillometric devices will actually measure the mean arterial blood pressure. And then they use like their own proprietary formulas to sort of calculate or estimate both the systolic and the diastolic blood pressure. So that in and of itself can kind of provide some inherent error. And will typically overestimate the blood pressure by like 3 to 8 millimeters of mercury. So it's not perfect, but from a practicality and also safety perspective with respect to thrombosis or ischemia, it's obviously better. So this is completely made up, but you have the baby that was born at 26 weeks is now corrected 34 weeks, still on CPAP, is getting caffeine, and we've got blood pressures pretty consistently 85 to 95, so systolic, over 60 to 70. So is this blood pressure abnormal, and do we need to do anything about it? I won't ask you to answer because we're all just going to look at the table anyway. That's what I would do. So the way that we define hypertension in this age group is if blood pressure is consistently above the 95th percentile for gestational age. And again, like I said, these are extrapolated data based on older kids. And so it's not exactly based on like regularly measuring blood pressure in these. So they're not perfect, but they give us something to go off of. And so this is what the table would look like. So for our patient who was 34 weeks, we said blood pressures were 85 to 95 systolic. So our 95th percentile is 85, so has been pretty consistently hypertensive over the last week. So we said yes. Oh, there it is. So now I think we can discuss basically how would we investigate. A lot of the investigations or the way that we can divide the different causes of neonatal hypertension are based on these categories. And hopefully what we can show is that even by just doing your history and physical exam, you can investigate or potentially assess for quite a few of these things. And then you have imaging and lab work as well, that can really help you identify what's going on. The ones that we will talk about that tend to be more common in the NICU are renovascular and renal parenchymal disease. We'll also touch briefly on chronic lung disease as well and its association with hypertension. But for when it comes to renovascular hypertension, by far, umbilical catheterization is one of the biggest risk factors, and will always be something that we will ask about or want to know about, for a number of different, and can cause a number of different things. The most common, of course, being thrombus. But these are some other things that can cause renovascular hypertension. Again, not something that we maybe don't see quite as commonly.
Can I ask a question? What's mid-aortic syndrome?
So this is like in babies who, for whatever reason, have had like not necessarily like a coarctation of the thoracic aorta, but something that causes constriction of the abdominal aorta certainly before the branch off point of the renal arteries.
Mm-hmm.
So it's in a way, it's kind of like a renal artery stenosis, but before, that's sort of the same.
So the kidneys are sensing like less perfusion pressure,
But
and because of that,
Yeah.
so basically there's like a thoracic compression of the aorta,
Yeah.
whatever is the cause of that, like a mass or something else.
Yeah, could be, or again, I don't know that we really see this in this age group, but things like there's like another entity that we see, like fibromuscular dysplasia, where they just have these like different constriction points. Patients with Williams syndrome as well, who have these elastin gene mutations, can have these stenoses at various arterial points as well. Or if they've had like some sort of abdominal procedure or a manipulation of their aorta, and then or a reanastomosis somewhere that then kind of gets stenosed or something like that. And that becomes a little bit tricky for treating because you're trying to fix blood pressure for their brain, but you also want to perfuse the rest of their organs, and so you're dealing with the big differential in blood pressure, so it's tricky.
Okay.
And then these are some of the things that we'll be involved with and see a little bit more. So autosomal recessive polycystic kidney disease, tuberous sclerosis, as well can cause like cysts and angiomyolipomas, and they're at higher risk for developing hypertension. Ureteropelvic junction obstructions. Then we see patients with congenital nephrotic syndrome that are very hypertensive as well. Similarly, I think what you guys might see also a little bit more is patients who've had like HIE, who have had a significant AKI, might be fluid overloaded, but not quite recover their renal function completely. And then these are some, again, a not fully exhaustive list of other potential causes as well. I did want to touch a little bit on chronic lung disease because you see a lot of that. Um, and we do know that, depending on the study that you cite, it's anywhere from like 10 to 30% of babies with chronic lung disease will develop some kind of hypertension at some point. It's not really clear what the mechanism between the two is. There's probably a lot of confounding factors involved. Um, there have been some studies that looked at like arterial wall thickness changes and systemic vascular resistance in babies with BPD and how that might be a mechanism for them developing hypertension. There's also been some discussion or some thought that like phthalates in different medical equipments, which I think is not being used as much anymore. But that, babies with BPD, they get exposed to these different plastics and things like that, and activating mineralocorticoid receptors and causing increased blood pressure. I don't know how true that is. I think probably what the most likely thing is that there's probably interplay between many different factors that influence it. You have these babies with chronic lung disease that were probably born premature, probably have not developed like a full complement of nephrons, probably have had some degree of kidney injury at some point, and kind of all of that together affecting the development of elevated blood pressure. And you may not see it as apparently because eventually they end up on diuretics and that will kind of help their blood pressure eventually as well. So if we go, back to our case where we talked about this baby. So from where do you go? Yeah. So this baby who we've seen has been a little bit hypertensive over the last couple weeks. Just from like a history perspective, I guess, what are some things that we could ask about?
If he had lines, which
Yep.
is most likely he
Yeah.
did.
Yeah.
Well, I mean, we can go like from the maternal history. So was mom hypertensive, preeclampsia, all of those things. Diabetes, you said
Iffy. Yeah.
maybe.
Yeah.
So that. I guess if it's a twin or not with TTS,
Yeah, that's a good point.
So if
Yeah.
mom was on any meds.
Yeah.
Oh,
There you go.
have it.
Yeah. No, I think that's all very, really good. And it's kind of like the general obstetric history that you would typically do. Any other like maternal conditions, maternal graves, like hyperthyroidism, something like that, can also cause hypertension in a newborn.
Joey, do you always do a TSH in all of these babies? Like, let's say there's no
The
history of a,
hypertensive babies?
yeah.
That's a good question. I don't know that people would necessarily, I don't know that I would have done it automatically, especially if they've had their screening and things like that. Unless I guess there was any concern that there was something in the mom that might have could
Missed.
potentially, yeah. But I mean, at a certain point, we end up doing potentially investigating so much. I don't think it hurts to.
Okay, I guess we'll talk about the investigation.
Yeah.
Like one of the question is, do you do a TSH, do you don't? And another one I had was, do you consider ever doing like an ECG plus or minus? I guess echo we'll discuss, but these are two questions I had.
And then, well, physical exam as well. Again, you've all like in your initial prenatal or not prenatal, but admission exam, you do a lot of this already. So forelimb blood pressure can already tip you off about whether there's coarctation or mid-aortic syndrome, for example. Your cardiac exam for any murmurs. If they've got like a big mass hydronephrosis, or is it like a congenital Wilms tumor or something like that. Genitalia as well, if there is any ambiguous genitalia or disorders of sex development, and any, of course, edema for that will affect things as well. And this was our big list of everything, but already just by kind of doing your history and physical exam, you've already assessed for quite a few things. Yeah. And then, right.
I'm sorry, is
yeah.
it the maternal cocaine and heroin? Is it like, does this influence the baby's BP even like 2-3 months after birth, or would that be the sort of
I think it would probably be earlier on.
Yeah.
Yeah. Yeah. Oh, I didn't want to give it away. There's like the thing on the other side, but I don't know how to get rid of that. But in terms of lab investigations, I guess I will always kind of consider a urinalysis as like almost like a vital sign in nephrology. But already that can give you some indicators. Of course, if they've got a Foley, for example, hematuria you'll always have probably a little bit of hematuria. But it can give you an idea about already if there's some kind of thrombosis, cortical necrosis with your history of asphyxia at birth, for example, or AKI with acute tubular necrosis. And then if there's significant proteinuria as well, which again can be kind of tricky early on, depending on what other factors might be happening. Any other labs, I guess, that, I mean, it's all over there, but.
Is it? Oh, very.
Yeah, but, and again, so, your UA, your CBC, creatinine, lights, urea, this all gives you an idea about, is there a chronic kidney disease, is there AKI? Blood gas, if you have, for example, something like pseudo hypoaldosteronism or hyperaldosterone type states, or even congenital adrenal hyperplasia, whether it's acidosis, hyperkalemia, metabolic alkalosis, all those things can kind of tip you off a little bit. I think we would probably find it more interesting in our involvement, but yeah. And then secondary labs. So I do have TSH on the list. Aldosterone and renin, cortisol again can be considered, especially if you're considering like the potential investigations for CAH. And then this is more for patients with like you think might have a neuroblastoma or something like that, and maybe less common in the neonatal period, but something that we consider as well. And so obviously nephrology is around and can help suggest some of these things. I don't think it's unreasonable to do the TSH right away if you're poking and doing a bunch of
So
stuff.
those you do like if the first labs are abnormal or if there's something you want to.
Yeah, or if there's something else on the history that might kind of go with it. But you can already kind of get a start with all that and narrow a couple things down. And even then, you're getting the ultrasound at the same time. And if you've got like a thrombus in the renal vein, then we don't really need to go and look for like a TSH or cortisol or something like that. The other, so the renal Doppler is always helpful when you're looking for a thrombus, for example, especially in a baby who's had lines. These studies, the VCUG or the MAG3, would really be more if you've identified some other abnormality on your ultrasound. And then an echocardiogram, and your question about the ECG as well. So I would have to look in like the neonatal period from like older child. It's not recommended to do ECGs just because they either miss or will overcall like left ventricular hypertrophy. And so anytime we start a patient on an antihypertensive, we'll ask for an echocardiogram at the same time just to see where we're starting from. But we don't ECGs are not part of the guidelines anymore.
And so on echo, what would be, I guess you look at left ventricular function, hypertrophy, dilatation, valvular function,
And
aortic.
and even the echo would be more like, because they probably haven't had enough time to develop any left ventricular hypertrophy from hypertension at that time. It would be more like, oh, are we confirming that there's a coarctation, for example, or our cardiac exam was abnormal and we get the echocardiogram.
But let's say like in a prem, you had like 2 echoes in the beginning of life that were no congenital heart defect. Would you repeat an echo, or is it mostly to see if there's like baseline left ventricular function, or you don't really need to repeat an echo?
I don't know that you would necessarily need to. I think it would also depend on like how long the hypertension has been going on.
Okay.
Yeah. And so with all of this, we have been able to identify quite a number of the different things. You can eliminate or assess for any number one of these with our full complement of investigations that we've done. And so, yeah, it at least makes it a little, it helps you narrow things down quite a bit. And sometimes you do all of this, and it's not uncommon that you don't find anything. And in those babies as well, then the question is, at what point do you start treatment, for how long, and how you follow those patients as well. And that would, I think, be more us following them over time. But so when do we treat, I think is an important question. And so there's not a lot of data on antihypertensives in this age group. In fact, almost none, really. And so even though the 95th percentile is considered hypertensive, what a lot of people say is that if you are consistently above the 99th percentile, then that's when you should start to initiate treatment. So the first step, of course, is addressing if there are any iatrogenic causes. And then your second step is a variety of agents that you have at your disposal. So these are just a couple. But one that we use quite frequently is amlodipine. It is a calcium channel blocker. It takes a while to kick in. Can take like 2 to 3, even sometimes up to 5 days to really start to see an effect, but it has a long duration of action. And so that can be useful for sort of chronic management, maybe less useful or less ideal for maybe smaller babies or babies where we're worried about instability down the line. You don't want to have a long-term long-acting antihypertensive on board. Diuretics like hydrochlorothiazide or furosemide. So if there's fluid overload, or eventually babies who have chronic lung disease will end up on diuretics as well. So you can kind of get 2 birds with 1 stone. Beta blockers we will also sometimes use, often as like an adjunct. Propranolol is one that we will often use in the neonatal period. And I think there was a baby that we were following anyway who was on it for a little bit. ACE inhibitors we try not to use until 44 weeks corrected gestational age. We typically in newborns will use captopril because it's quite a short onset of action, but also the duration of action is quite short. And it's anywhere, I think, from like 2 to 4 times a day dosing. So if you need to stop it or you don't want it to be around anymore, you just skip doses. And so it's pretty convenient from that perspective. Of course, then you are also dealing with hyperkalemia, potentially. In some cases, quite profound hypotension that is not responsive to fluids as well can occur. Again, more so in smaller, younger babies. But even like if for whatever reason we have to start infants on ACE inhibitors, even older babies will often admit them to initiate which we've done before. just because sometimes initially they can become quite hypotensive. And so every case is a little bit different, and you can sort of tailor your treatment based on what is best or most appropriate for your.
Question for you, Joey. So I know for like the pulmonary hypertension guidelines, we never use calcium channel blocker in the first year of life because it has like um, an inherent negative inotropy. So, and these patients can have RV failure, so there's more mortality. Versus if you're above a year of age, it's the first line if you're vasoreactive. So one of the question I always wonder, like, let's see, you get your echo, and we've seen some patients who have like high BPs that end up with some degree of LV dysfunction. Would that be your first line? Would you diurese them first? Like, what would have been, would you still go with a calcium channel blocker?
I think, I guess at that point it becomes, I think, a discussing with cardiology and NICU about what would be the best approach.
Like, would you start with like IV? Like, let's say they're very hypertensive for various reasons. Like, would you start with like milrinone or hydralazine? Like some of more, I guess it's coming with the severe hypertension, but
yeah, I think, I mean, I would discuss it with the team and see if really there's a concern about the negative inotropy with a calcium channel blocker, for example, then do we need to do something else? Is the age of the baby maybe more amenable to an ACE inhibitor, and would we be okay with that? Yeah. I don't know if I would have like a off the bat answer about that. And severe hypertension, I think, is probably even more rare in the NICU, but can happen. And the definition is not very clear in terms of what actually constitutes severe hypertension. From what I had found is if there are 10 to 20 millimeters of mercury above the 99th percentile, that might count. In like older kids, for example, we'll say if we have sort of different percentiles and stuff, but if they're like, I think 30 millimeters of mercury above their 95th percentile, we'll sort of do that. But certainly if there are like even any symptoms related, again, which can be very nonspecific and difficult to ascertain depending on the clinical situation. But that would also constitute severe hypertension. And the general investigations are typically the same. But I guess maybe a little bit more exciting, or I guess, more ICU of a case, is this baby. And this is actually based on, didn't remember all of the details, but this is a case that I had seen during my training here. Which was like a very rare thing, but just to give you a kind of an extreme example. But this baby that was admitted, I think ultimately the first baby was like transferred from another institution, but this, whatever, for the purpose of this, it was a term baby, and that was admitted to the NICU. Initially had some TTN, and then over a couple of days develops hematuria and AKI, becomes fluid overloaded, and has anemia, thrombocytopenia, and hemolysis. And then the blood pressure starts to increase quite significantly, and then the baby starts to have seizures. So how do we manage the blood pressure in this situation, and what are our targets for managing the blood pressure as well? Have you guys seen or thought about this, or?
Well, my first thought is, since he's having seizure, number one, is it related to the actual hypertension or not?
Right.
Like, is there any other things like, LP, make sure it's not infection.
But sometimes you won't know either.
Exactly. But one of the things is that just the treatment for seizures are medication that can vasodilate a lot, right? So
That's a good point.
So phenytoin, all these drugs, like if he ends up on like some kind of benzo, that can also alter your BP. But I'll let Laurence.
On the spot.
Yeah. So in terms of management, I guess I would use something IV that like acts, like rapidly, and then where's it rapidly
Yeah.
if the BP is going too
Perfect.
like low.
Yeah.
So that, and then go ahead.
No, please.
No, and I was gonna say like how quickly. So my understanding was like in these situations we want to bring it down like a bit, like 25% or something, and then later on you
Perfect.
bring back down the norm.
Yep, exactly. And so that's spot on. And so oftentimes it's a good point. Actually, I hadn't even thought about like the anti-seizure meds bringing the blood pressure down. But what we'll usually prefer is exactly like Laurent said, something that kind of comes on quickly and can wean off quickly as well. And we have a couple options. I would say the one that is, especially in like the newborn period, the one that we would typically prefer or use more frequently is nicardipine, also a calcium channel blocker. Compared to like beta blockers. Nitroprusside is another one that is like a direct vasodilator, less ideal in like kidney failure, and you have to monitor for cyanide toxicity as well. And in our hospital, the test to assess for the thiocyanate is a send out.
So it takes time.
So it comes back in like 2 weeks. So it's
Oh,
completely
so you won't know.
useless.
Yeah.
Yeah.
Okay.
Yeah. So it used to be, I think we used to get it back, and then they moved it to a send out, and now it's kind of useless. So you can use short-acting like bolus medications as well. The downside of that is that they'll work quickly. Their effect might be a little bit unpredictable, so you don't know how quickly you're going to drop the blood pressure either. And then typically it'll go right back up. And so you have to keep giving these boluses as well. So those are your short-acting IV, and then there's short-acting oral medications as well that we have. Here we use nifedipine. Again, also a calcium channel blocker. But I guess what is the potential danger of bringing the blood pressure down too quickly?
I mean, I wouldn't be able to explain it super
That's
clearly,
okay.
but like if the BP goes down too fast, then the perfusion,
Yeah.
which has become accustomed to like having like
Yep.
a high BP, then
Exactly.
it's not good.
No, that's
Your
exactly right.
understanding.
Yep, exactly right.
The flow may not adapt to
Yeah.
main
Oh yeah,
perfusion.
Yeah. So the brain will, especially if it's chronic, or we consider, I think anybody beyond 24 hours of elevated blood pressure is just consider it chronic. You could probably get away with like up towards a 48, but I think everyone will want to be on the safe side. And exactly right, you're going to have concerns for cerebral hypoperfusion and ischemia. And so if they've had a chance to have like cerebral autoregulation with this higher blood pressure, if you suddenly drop the blood pressure too quickly, you will hypoperfuse the brain. And that will also be very difficult to assess in this age group and in a baby who maybe already is symptomatic and having seizures. And so your goal blood pressure is to get eventually down to the 95th percentile for their gestational age. And exactly like you had said, Laurence, so the first step is to reduce the blood pressure by 25% of your total goal in like the first 6 to 8 hours, and then to bring it down gradually over the next day and a half to the 95th percentile. So if we say like for a 40-week-old baby who's symptomatic with blood pressure of 124/80, their 95th percentile is 95/65. So you want to eventually get the blood pressure down by 30 millimeters of mercury. And so 25% of that is 7 so we'll just say 8. And so to go from 124 down by 8, I give a range because
Good luck.
yeah, good luck getting exactly so even this is probably a pretty small range. But you want to get it down to this over the first 6 to 8 hours. Once you've been able to establish that, then you can gradually decrease your blood pressure goal over time to get to your 95 millimeters of mercury systolic. And that's how I would go about it every time. And you can also be, it's not like cookie cutter. You can be a little bit more conservative, and you can say, oh, well, let's get them to the 99th first, and then we'll see how things go. Um, but that's kind of how I do it, and it's so much easier to titrate that with a continuous infusion than with bolus medications.
So
Yeah,
you just
question?
like start nicardipine and then titrate like 0.5 and then titrate 1.5, whatever,
Yeah.
until you get the BP and then
Yeah.
leave it there.
And then often what we'll do is like then initiate like a long-acting
Yeah.
medication that okay, it'll take time to kick in, like your amlodipine, for example, and then the blood pressure, you can start increasing the nicardipine. And the goal is that eventually, by the time the amlodipine is kicked in, then you can kind of start to wean off of the infusion, and you slowly replace with your oral antihypertensives.
And the nicardipine is short half-life.
Yeah, not as short as something like labetalol, for example. I think even nitroprusside is even shorter. I can't remember the exact.
But like you would expect the effect within an hour of
Yes.
infusion.
Yeah.
Or even
Even
shorter
shorter,
than that,
even
like
shorter.
15, 20 minutes,
Yeah.
you should see an effect.
Yeah.
And then you don't know if it can be run with other drugs or TPN. It has to have like it's online, probably.
Oh, I don't know about
Would have to check the compatibility.
And I think that's, I mean, an important point in terms of access and everything.
Because sometimes we choose drugs even that are not the ideal one because of access issues.
Yeah. And I think that also will absolutely influence your choice, right? Like we can say start something, and you're like, well, where are we going to put it? Like we need to get this blood pressure down. So it's a good point. Yeah.
Do you give sometimes a bolus? I guess not, because you want to be more careful at dropping it too quickly, or
the ones that I've the most commonly given a little bolus were with labetalol.
Okay.
And oftentimes even like the initiation. I think that's a spam kebab.
Most likely.
Yeah. Labetalol will and even part of like the initiation process or getting them onto the infusion will be like to give a bolus and then start the infusion.
Would you sometimes consider like agents like milrinone, or not? It's not part of your area of
No, it's not.
Okay, interesting.
I'd be more comfortable playing with
Milrinone.
For sure.
Your problem with milrinone is that if the kid is seizing,
I know.
it's not gonna act out.
For sure,
Milrinone takes like 2 hours sometimes to function. So
I would just
that's one of the disadvantage of that drug.
makes sense.
Yeah.
Prefer it, but
I know. But we talk about hypertension, but we see situations where we have patients that are failing their heart, and part of the failure process, we need to reduce afterload very quickly. So of course, we're comfortable with milrinone to try to afterload reduce these struggling LVs that are not able to function. But like our ICU counterparts, they may use much more aggressive strategies. They use like nitroprusside, they use hydralazine, they use sometimes nicardipine.
Yeah.
The problem with nicardipine or some of the esmolol drips and things like that is that it does have some inherent inotropic negative inotropy to these infusions. So if you're trying to rescue a left heart that's like dying, you're not going to use the beta blockers or the calcium channel blocker, because you're a bit more concerned about its side effects for the heart. So that's where hydralazine and nitroprusside may be a bit better tolerated, but not necessarily because they are in like high SVR state. It's really because you're trying to modulate SVR as part of the bigger picture, where they have also a cardiogenic kind of component to their condition.
That's interesting. I think also at that point, like we're kind of out of our depth with that sort of thing, and it becomes, I think, important to discuss as a team in terms of what the best thing is. And I think ultimately, if they're on antihypertensives long term and things like that, it's helpful for us to also understand a little bit about like the
initial
physiology of it and what brought it on, and so that's cool because I don't think that it's not exactly something that comes up in
our
general
discussions,
nephrology teaching
yeah.
otherwise. So yeah. Um, and then the general outcomes as well, like are again very much depend on what the cause of the blood pressure is. Obviously, if they have kidney disease, well, it's going to be lifelong. Versus things like if it's just related to a line, um, or any endocrine or cardiac causes, you just obviously address what the main cause is. And then oftentimes what we'll also see is that it's just, I don't know, it's almost like this transient hypertension of the NICU that some babies just have, that they're, for whatever reason, become kind of hypertensive, and in the NICU, we don't really ever find any cause, and then we just kind of keep following them as older babies, and over time we're able to wean off of their antihypertensives. And I don't think that we really understand why that is. And those also have generally pretty good outcomes. But I think from like I mean, there hopefully are a couple takeaways from this for you guys, but I would say that, we know that blood pressure changes can be very, very different depending on the age and the size of the baby. We have, I guess, particularities about how we measure the blood pressure. I think that there's a difference, though, between, I guess, like getting it accurate, but also what is practical and feasible on a regular basis in the NICU. And I think that in a lot of cases, if you have like a list of potential causes, a lot of the initial investigations that you do can help narrow it down. And I think having a good understanding of what, in severe hypertension, what your BP target is. And I think especially, I guess, when you're dealing with heart failure or cardiac pathologies, is that I mean, I'm learning more, discuss with NICU and cardiology about what the best agent might be. Um, and yeah, those are kind of the big things. So I hope this was useful. If you have any feedback, or if there was something that you would have liked to see or would want to see more of, please let me know.
That's amazing.
It was really clear.
Thank you, Joey. That was great. Honestly, it was very clear for us because it remains a bit of a black box for us sometimes, hypertension. Also, we see it like acute, like we see numbers and we're like, oh, repeat your blood pressure and then ask nephrology, and then it's like transfer to the wards or go somewhere else and then figure it out,
Yeah.
But I think for us in the NICU or in our ICU setting, we will face some of these patients, especially as we're seeing more and more extremely, extremely growth restricted patients. I can sense that they have some kind of vascular reprogramming that will put us more or confront us more to the situation. Also, the patients we do see are those who develop lung disease and they develop like some component of pulmonary hypertension. And then it becomes very challenging to decipher whether there's a component of strictly like pulmonary vascular disease or could they have like some kind of left-sided condition. So if you had high systemic vascular resistance for a while, even if it's does not translate in clinically hypertension because the numbers you measure look fine from your tables, but for that baby, the SVR are not necessarily what it should be.
Right.
Let's put it that way. They do end up with that component of like LV alterations, and you mentioned they have probably some acute kidney injury, injury from iatrogenism, from the fact they're born preterm, from nephron, kind of the capital of the bank of nephron that they have.
Yeah.
And then, on top of that, they may have renin, angiotensin, steroid pathway changes. And we see some of them have like this kind of LV phenotype where their left ventricle had maladapted in that context for like days and days and days and weeks. And that seemed to also contribute to their, post-capillary drainage of the lungs. So they get these LV that are stiffer, that are fibrosed, that are ischemic to some, microischemia, microcirculation of the LV. And then they end up with more stiffness of that left ventricle, and they end up with more issues regarding lung perfusion and lung drainage. So we detect it as like, oh, they have abnormal pulmonary hypertension. But then, some people would just like throwing pulmonary vasodilator at these patients where probably you should be considering like first line diuretics. That's what we typically will do, which probably addresses a bit of the systemic compartment and the pulmonary compartment. And then if you end up with a phenotype of full-blown systemic hypertension, I do think that in these patients, you should first address the systemic hypertension. And I think calcium channel blocker, as I just said at the beginning, are not necessarily recommended for the kids that are less than 1 year old, but you're probably killing one bird, two stone, one stone, two bird. I don't know what's the expression. So it's two bird, one stone. So just for you, Laurence, like the recommendation for the pH guideline is that typically when you have pH that are thought to be from pulmonary vascular disease, and you go to the cath lab, which we most of the time don't for these patients anyways, you do what we call an acute vasoreactivity testing, which means in the cath lab, you'll give them oxygen, you'll give oxygen plus nitric, you'll give nitric only. Some centers will give inhaled prostacyclin, some centers will give adenosine. And we'll see the reaction of the pulmonary vascular resistances. And mostly they'll look at what's easy to deduct is the mean pulmonary arterial pressure. So they'll see, do you have a drop of more than 20% of your MPAP? And if you do, you call it a positive reactivity testing. And your first line treatment in North America is always calcium channel blocker, except if you're less than 1 year old. That's like a big no-no. If you go to Europe, there's centers that would still put calcium channel blocker in these kids because it confers them a very good prognosis for their pulmonary hypertension. It's very different than the kid who's not reacting, because in the zone of IPAH, FPAH, genetic PAH, they often have poor reactivity. So, they're not going to be put on calcium channel blocker. But I do have a sense that a lot of these BPD patients that do end up with some pulmonary vascular remodeling probably have reactivity. And so if they have systemic hypertension, then you put them on this calcium channel blocker, then, because for this it's indicated, unless of course at your echo assessment, you see there's cardiac dysfunction. And then you need to discuss with nephrology and with your cardiology team and for the long term, okay, well, how will we manage this patient who's 40 weeks with high pulmonary, pressures estimated on echo and some signs of systemic hypertension. And as you remember, if you have systemic hypertension, a lot of your markers on echo, like you won't necessarily be able to rely on septal curvature. Because if your systemic BP is 100 and you have your PA pressure is systolic, 75, you're going to have a very nice round LV, but maybe you'll get at this point a TR that gives you these high numbers of systolic PAP. And so there is something downstream in this pulmonary vasculature that's causing elevated PA pressures. And so if they have robust contractility, I think at that point, diuresis, calcium channel blocker monitoring with your nephrology team, renal ultrasound, all these things. And then if ever you have cardiac dysfunction, that's when it needs to be discussed. Like how acute is the cardiac dysfunction? Like, do we use IV? Do we need to start considering milrinone to support the cardiac function, try to drop afterload? Do we end up with, choosing ACE inhibitors if the kid is judged to be appropriately mature enough to start this medication? I know some centers are using enalapril in some of these particular cases I just described where they have this kind of biphenotype. There's a few case reports from Australia.
Once they're at term.
Once they're at term. Yeah, the exact scenario I just mentioned, like a kid who has like signs of LV hypertrophy and systemic hypertension, and there's elevated RV pressure on your echo, and you want to kind of address this LV phenotype to see if you're going to help the drainage of the lung, but as well as the blood pressure in the systemic compartment. But of course, we're not going to be the one following these patients, so it needs to be done with the pediatric nephrology team and discuss if that kid is eligible for that.
Makes sense.
And you talked, like when you mentioned about even if a baby doesn't necessarily meet criteria for, let's say, systemic hypertension, you still want afterload reduction. I've had consults before too, where more in the PICU, for example, where like this kid is started on labetalol or nicardipine for whatever for an older kid, but for afterload reduction, and they're like, oh, why is the blood pressure so high? Like, why did we need to start this? And I remember looking back and thinking this baby never had hypertension, but they wanted
to afterload reduce
like, okay, well,
to support the heart
yeah.
function.
So it's interesting. Yeah.
And then I guess also for us, we see many babies who have like residual shunts, like mostly post-tricuspid shunts, but I think if you have a VSD, it's not necessarily the main problem. But if you have like a large PDA or some degree of PDA that steals and can be potentially associated with chronic renal hypoperfusion, and which would either reprogram your kidney or drop a bit your diastolic pressure. I find the challenge when you have these systemic high systolic numbers and then low diastolic numbers, and it's like kind of almost compensatory.
Yeah.
So then I would say if you have that situation, you would probably need to assess at that point whether or not you need to go do a cath kind of closure. And then after that, reassess. Exactly, because you're going to change your hemodynamic and systemic, So before throwing agents to like afterload reduce in a kid who has a large PDA, I would say if you're at term and you still have that,
Maybe
you would need to
address
consider
the
closing it. Exactly, because it's kind of a potentially reversible cause. And then once you've closed it, we see patients post-closure that develop like for the rare cases that we do, there are patients who develop like a phenotype of severe hypotension post-ligation syndrome. Of course, these ones will need like a rescue because it's mostly like a cardiogenic, primarily shock picture because the LV was facing such low resistances from the PVR and was getting very preloaded by the high QPQS. And suddenly you're cutting abruptly the preload and dramatically increasing your afterload. So your LV is having struggle. And so you get into this cardiogenic shock picture. So, often we'll preemptively put them on milrinone to drop the SVR so that when you cut, they're not facing these massive SVR that have been like so tightly trying to constrict to maintain perfusion pressure. But then there are phenotypes where some of these kids have such high renin, angiotensin, and adrenergic circulating hormones that some of them actually, especially if they're a bit more mature, like closer to term, when you close them, they have like a period of hypertension. They actually develop hypertension because they need to clear off and reprogram, and they have all this renin, angiotensin, and adrenergic hormones circulating from all the stress and the chronic kind of steal effect. And so we see, and there's, I'm aware of a case of a colleague of mine who kind of contacted me and said, oh, we had this case where we ligated, and this was a term infant and had this massive duct and was a week of age. We went to ligation or cath closure, and the kid post cath closure had these like extremely high systemic pressure. So they ended up, having nephrology, and they had to treat for like a few weeks with calcium channel blocker. And I think they use ACE inhibitors, and once the cardiac function got better, transitioned back to like a calcium channel blocker because it's kind of the first line they typically will use to help the SVR kind of go down.
That's cool.
Yeah. So we see hypertension in our rarely.
We see hypotension.
Yeah.
And some hyper. So it was a good
but it's something you need to be aware of and what to do when you face like acutely or more chronically and understand the pathophysiology. Also in growth restricted and placental dysfunction fetus, it's like fascinating the physiology of why they develop that. I think part of the mechanism is thought to be related to like the placenta shedding neurohormones and hormones and cytokines and inflammatory markers that remodel the systemic vasculature. Part of it is thought also to be compensatory, like they sense that they're hypovolemic or there's less flow coming back. And so because of that, they constrict to maintain perfusion pressure. But part of it could also be, some people are thinking that because the fetus is facing these high placental resistances, that, and the flow sometimes even is retrograde. So this aorta is reacting to this high SVR status. And you get also a change in the property of like your shunting directionality. So normally you get this torrential right to left shunt at the ductal level. But if your SVR are rising, the actual amount of volume you're sending from the PA to the aorta diminishes. And because it diminishes, part of it creates a reaction where the aorta has to constrict a bit more because there's less flow kind of reaching the lower body, and then there's more flow kind of being pushed into the pulmonary vasculature, which increases left atrial preload, and the left atrial preload increases the LV preload, and eventually this LV becomes more hypertrophic also because of that. And then your output in your aorta changes, like the way it behaves, and it creates this like kind of continuous circle from like where you get less flow, and so there's definitely remodeling that starts taking place because of that. And then renin and angiotensin starts embarking, and then and it's like a vicious cycle of and that's why some of these patients end up hydropic. Right, because they end up in failure because their ventricle are not able to cope with the resistances. Yeah, cool. Super interesting. Yeah, thank you, Joey. Any other questions?
No, it's really clear. Is the presentation available, like the slides?
Oh yeah, I can email it too.
Yeah, perfect. We'll make them available to the NeoCardioLab community. Thanks. Amazing. Okay.
It was really
Thank you so much, Joey.
Thank you for having me.
Recording here.